You're listening to Save Your Thyroid with Jennifer Holkem, the podcast where we explore how new technologies and non-surgical procedures can be used to treat thyroid nodules. For years, patients facing the diagnosis of very large thyroid nodules or a massive goiter were given a single daunting path, highly invasive surgery. In the most complex cases where the thyroid grows deep into the chest, this could even mean a sternotomy, a procedure that involves opening the chest bone to reach to the deepest depths of the gland. A few years ago, we saw a revolution with the arrival of non-surgical technologies like radiofrequency ablation, RFA, and microwave ablation, MWA. These technologies have been life-changing for many, but they have a size limit. For those with massive goiters, sometimes above 4 times the ceiling size limit of a standard nodule, ablation isn't always effective, leaving these patients right back where they started, facing the operating table. However, a powerful alternative called Thyroid Artery Embolization, TAE, has stepped into the gap, treating the thyroid through its blood supply rather than through heat or needles. TAE offers a way to shrink even the largest goiters while preserving the organ and avoiding the scalpel. Our guest today is at the absolute forefront of this innovation. Dr. Juan Camacho is an interventional radiologist at Radiology Associates of Florida and Sarasota Memorial Healthcare System. Trained at Emory University, Dr. Camacho has spent the last decade at some of the world's most renowned academic institutions. During his time at Memorial Sloan Kettering Cancer Center, he was a pioneer in thyroid ablation trials, and he has spent his career building bridges between interventional radiology, endocrinology, and surgery. Today, he is leading the charge in refining TAE techniques to make them safer and more effective than ever before. In today's episode, we're going to cover why traditional ablation often fails for nodules larger than 20 milliliters and why TAE can be the solution for massive cases, the science behind the pressure-enabled delivery PED-TAE device, Dr. Camacho's recent publication showing a 73% volume reduction in massive goiters, details on the new 10-site multi-center research study that is setting a new standard for thyroid care. Dr. Camacho, welcome to the show.
Thank you, Jen. Thank you for having me. It's always a pleasure to be able to reach out directly to the community, to be able to engage with our patients, and to try to have the opportunity to enlighten them and share our experiences and try to educate them. That's something that I really enjoy. So thank you for giving me the opportunity to be here.
Absolutely. This is a three-peat for you, I believe.
I think
Having you back on the third time, and I just love it because I always enjoy our conversations tremendously. So I'm going to really quickly, before we get into this conversation, set the stage by kind of reading over a summary of this study we're going to be discussing today. So the study is called Safety and Efficacy of Pressure-Enabled Thyroid Embolization, a novel approach for symptomatic thyroid disease. And this was published in the Journal of the Endocrine Society. These are the highlights of the recent study on pressure-enabled thyroid embolization, or PED-TAE. The study looked at 22 patients with complex conditions, including multinodular goiters and Graves' disease. These patients were treated using a pressure-enabled drug delivery device, mostly through a small access point in the wrist. The results were remarkable. Technical success was achieved in 100% of cases. The mean gland volume dropped from 184.5 milliliters down to 49.9 milliliters, a 73% reduction in just 6 months. 71% of patients with hyperthyroidism returned to normal euthyroid state, and there were zero neurovascular complications. That's amazing. This data is particularly striking because ablation is generally considered ineffective for volumes over 20 mLs. The average thyroid volume present in the study was 117 mLs, almost 4 times above the threshold for effective ablation treatment, highlighting the challenge of using ablation as a standalone treatment modality in this patient population. So now that we've covered kind of the gist of it, let's dig into the meat and potatoes. So let's talk about the size problem. This is the biggest question I get from patients when they want to know, can I have 5 RFAs to deal with this massive goiter? Why would I need to do something else. So talk with us about why RFA or any other thermal treatment isn't really effective for these really big nodules over 20 mLs. Why is there this ceiling?
So there is a very important phenomenon that happens inside the thyroid, and it's a physical phenomenon that is called a heat sink. Essentially, what that means is that the thyroid, to begin with, it's a very, very, very vascular organ, and the pathologic phenomenon that leads to enlargement of the goiter, it's cellular hyperplasia. It's essentially some cells become rogue and they start reproducing abnormally and they grow. They don't necessarily evolve into a cancer, but they're reproducing abnormally, and that leads to hyperplasia. And that's ultimately the pathological phenomenon that happens inside the gland when you have a nodule or when you have a goiter, or even in some situations when you have Graves' disease or even Hashimoto's that can come with enlargement of the thyroid.
Mm-hmm.
So when you have hyperplasia, those cells require or have a higher metabolic rate. They will require more blood supply, which means that automatically they start sucking off more blood. And
Mm.
by doing that, they stimulate the growth of some of the blood vessels themselves. And they also stimulate creation of new kind of like abnormal blood vessels that start taking care of the thyroid.
It's almost like a
So
vicious circle then. It's like the extra growth factors are increasing everything to grow.
correct. So
Okay.
the larger the gland becomes, the larger the blood vessels that supply it are.
Okay.
So just to give you an example, there's a lot of blood vessels in the vicinity of the head and neck. You have the carotid artery, you have the subclavian. The carotid goes into your brain, the subclavian goes into your hand. Usually those vessels are about 5 to 10 millimeters in diameter. The vertebral artery, which is another artery that goes into the back of your brain, measures usually around 4 to 5 millimeters. Sometimes you can have thyroid arteries that are actually the exact the same size as the subclavian as well as the vertebral artery. I mean, they become significantly enlarged. So that tells you that there is a vascular component to the disease. The way we approach it endovascularly is by knocking off that blood supply that deprives these cells that are kind of like in a stress mode from blood supply. And by doing so, you're inducing ischemia or cell death. And when
Mhm.
that happens, then the body takes care of that debris in a natural fashion and it just kind of like resorbs that abnormal tissue. And
Mm.
that's what ultimately leads to decrease in volume. So that's kind of like the rationale why these works. But going back to the beginning is you have a very vascular tissue. You have a very large web of blood vessels because they're large and they're multiplying inside the thyroid. There's a lot of flow circulating throughout the tissues. When you have flow around a tissue and you're trying to deposit some form of energy, let's call it heat, let's call it cold, however you want to call it, if it's a phenomenon that requires temperature, just by you having these blood vessels circulating, they're going to cool down the tissue.
Mhm.
So it's not going to allow that energy to be deposited appropriately within the gland. So when you're thinking that you're creating a 7 millimeter or a 10 millimeter ablation with your radiofrequency probe, actually it's probably cut by half or by a third. So that means that you're going to have to make more passes through the same area. You're going to have to deposit more joules, which is a way we measure the energy that we put inside the gland. And ultimately, sometimes this is just ineffective because you cannot burn as efficiently. So that's the limitation that thermal ablation has inside the gland. And that's why this is an alternative that can overcome that limitation.
Yeah, when you're describing the heat sink, I'm envisioning someone trying to build a fire while someone is simultaneously trying to put it out.
Yeah.
And so
And
it's like it's just counterproductive.
exactly. If you have there's a difference if you have like a huge fire in a forest and you're just trying to put it out with a little tiny bucket. Well, we know that
Yeah.
that's not going to work. This is the other way around. Have a dam, like you have the Hoover Dam ready to go on top, and you have a tiny little uh fire just adjacent to your campsite. Well,
Yeah.
that's just going to go away. So it's just not enough to overcome the amount of heat that is being stolen.
Wow, that's such a great example of just how important it is to know what the limitations of your tools are, and then for doctors to think outside the box to come up with these different treatment options for these patients, because we're talking about patients here with these types of goiters sometimes have to have their sternum cracked open to be able to access the deepest parts of the gland. How, just out of curiosity, how far down have you seen a thyroid actually grow into the chest?
Significantly, I've seen it behind the heart. I
Wow.
mean, extending for 15, 20 centimeters inside the chest. For example, today I actually did the largest gland that I've ever done. It was an elderly gentleman on the right side diving into the right lung, collapsing his right lung and measuring approximately 600 ml. So that's almost 30, 40 times the normal size. And the only way of getting to that is like you would need a full sternotomy, thoracotomy. It's a huge, huge surgery
Mm,
for a gentleman like that. With this, it may require multiple sessions. I don't have a follow up yet, but at least this can help. It's not going to make it perfect, but if we are able to achieve 50%, 60% volume reduction, that's going to have a significant impact. And I think that we can always do it again. So I think that the most important message here is something that you've shared with your community all the time, which is there's always options. There is not such a thing as a one shot treatment for everyone. You need to see patients in a multidisciplinary fashion. You need to offer options because ultimately, not all the options are perfect. Not all the options are perfect for everyone. And this particular option may help in very particular scenarios, and I hope we get the opportunity throughout our conversation to talk about that as well.
definitely. I totally agree. There's always a use case. There's always
Yeah,
individual people with individual needs. And so I'm so excited that this is an option for people who really need this. So you noted a lack of research in this area and that treating these nodules with these minimally invasive tools, having the options besides surgery, what led you to trying to fill that gap?
so what truly drove me is that we were having failures to treatment,
Mm,
and I was required to treat many times patients 2 or 3 times, and we were having complications. I mean, the reality is that all of these procedures are safe, but they can always have complications. And I think that the complications are rare, but we all have faced a thyroid nodule rupture. We all have faced, patients with significant pain because you have to have multiple passes. You have to treat multiple areas of the thyroid. You, particularly, for example, I know you've shared that you
yeah,
had several ablations as well. So, over the course of several months, I wanted to try to find a way in which we can continue to treat these patients more expeditiously and with less clinical encounters, right?
definitely. That's awesome. Well, so we talked in the intro about this term PED, pressure enabled delivery. For the layperson, can you explain what is that and how is it different from standard embolization techniques that you used in the past?
Absolutely. Thyroid artery embolization, I want to share that it's not necessarily a novel technique on its own. It's a procedure that has been around for over 30 years. The actual first case report that I've encountered what came out in 1994.
Wow.
So it's been around for a long period of time. Obviously, the greatest experience have occurred in areas in which goiters and multinodular goiters are endemic, meaning Asia, Italy, Poland, some of the Eastern European countries, and not necessarily in the United States. The traditional way it was described, it was that you have two arteries on the top of the gland and two arteries on the bottom of the gland. The two arteries that are on the top of the gland are branches of the carotid artery. The carotid artery is the one that goes into your brain. Two branches that are on the bottom of the gland are the inferior thyroid artery, which are branches of the subclavian artery, which is the one that goes into your hand. So the recommendation was to treat 3 out of the 4 vessels, just to leave one open, to prevent the theoretical risk of damaging the parathyroid glands, to prevent the theoretical risk of hypothyroidism, so damaging the function of the thyroid, pretty much out of caution. People didn't really know that you could embolize the 4 vessels safely. Then the technique kind of like evolved, and people started treating patients with grave disease, predominantly in China. And the papers from that era that focus on the treatment of grave disease started treating the 4 vessels at once.
Wow.
And
Okay.
and they noticed that it was safe. Nobody became hypothyroid. There's only one dubious case of potential hypoparathyroidism, to my knowledge. And it was just a patient that they didn't have a baseline calcium level, and then immediately after the embolization, he became hypocalcemic, meaning low calcium levels, but then it returned back to normal. So because it was a confounding factor, they attributed to potentially the embolization. In my experience, I haven't experienced any hypothyroidism or any hypoparathyroidism, but it was a theoretical risk. And the most important thing, and the elephant in the room, is that when you are treating the branches of the carotid artery, because you were targeting either the 2 on top or 1 on top, because your target was to treat either 4 vessels or 3 vessels, there was always the risk of non-target embolization. So non-target embolization means that the particles or the material that you're infusing inside the thyroid arteries doesn't stay in the thyroid gland. It goes somewhere else. And that somewhere else, if you're operating in the vessels that are going into your brain, means that you can potentially generate a stroke. And this is not unique for thyroid embolization. When you look at this judiciously, the Society of Neurointerventional Radiology, which is kind of like the organ that governs head and neck embolization, they quote a risk of up to 10% in stroke. Be very high. It's obviously way higher when you're operating close to the base of the skull or inside the brain. And if you're operating closer to the clavicle or kind of like in the lower portion of your neck, then the risk it's way lower, and they describe it up to 3%. Being specific with thyroid artery embolization, I honestly genuinely think that the risk of stroke, it's low. It's probably 1 to 3%. I will want to dare to say that it's probably less than 1%.
Wow. Okay.
Um, I think that if you're judicious with technique and if you know what you're doing, I think that the target number should be that. Have I seen strokes and have I had a stroke? Yes. Actually, in my experience, I have had 1 stroke in over 100 cases now. The important thing is that you have to do everything you can to avoid such an outcome. So again, going back into the literature, in the literature, there's about 8 cases reported. 1 that was a catastrophic stroke, and the other 7, they have temporary deficits that came back over time. And those temporary deficits could be a temporary loss of vision, for example. That was something that has been commonly reported, or problems with imbalance of when you are ambulating, or problems with swallowing
Okay.
because the back portion of your brain was impacted.
Okay.
But those are things that can be improved over time with therapy. And typically, the strokes that occur are because of reflux of particles. And the particles that we use are super tiny. You can only see them under the microscope. These are
Oh,
not things that they're not measured in centimeters or even millimeters. They're measured in micron. So in order for you to really cause a catastrophic stroke, you have to typically have an occlusion of a large vessel that goes into your brain, like a main branch that goes into your brain.
mhm.
Those are the ones that people hear about, I cannot use my arm anymore, or I cannot use half of my body anymore. Those are kind of like the catastrophic ones. We typically don't see this. And the ones that I being aware that have had bad outcome is because they have converted into a hemorrhage. And that's something that in the stroke world, it's also a very unusual scenario, but can also happen. So I'm telling you all of these things because I want to educate people that yes, this is a risk of the procedure. Yes, it has been described. Yes, if you go into the societal guidelines, it can be a very high risk. However, we feel that it's probably on the lower side of that 1 to 10% risk that is given in the societal guidelines because we're closer to the lower portion of the neck. And we take several precautions from the interventional radiology perspective for that to prevent such outcomes. Something that is also very interesting is that in the old days, when people were undergoing contrast injections in the head and neck, just contrast injections, just pure angiography, which is putting a catheter, injecting contrast, and try
Hmm.
to visualize the blood vessels on the inside of the head and neck. A lot of people were undergoing imaging right after, and they randomly found something that is called silent strokes. And what that means, it's very frequent. That happens in about 30% of the people, and very, very frequent. And
Mm.
these silent strokes are simply, we're calling them silent strokes because we don't have any other term to give it to it. They're not necessarily strokes, they're imaging findings that look like a stroke, but patients are completely asymptomatic. So I think that that's where all the societal guidelines come from. That's where all the potential fears to the procedure come from, because this is a term that is very frequently used in our world. And it's something that does happen, but we don't know what they mean. And it's certainly a phenomenon that occurs. And we feel that the clinically significant stroke, meaning a stroke that is going to cause you symptoms, is probably way under 1%.
Mhm. Okay.
So the reason why I wanted to develop something new is to try to prevent such outcomes. That we live in this world and we have had strokes for different reasons, because we are treating a stroke. Like in my practice, I used to treat stroke, or because we are doing angiography of the head and neck, or because we're doing just angiography for other reasons and we happen to have a stroke. It's something that really destroys you. As a
Yeah.
doctor, it's something that really creates an emotional wound because you never want to cause harm to anyone.
Absolutely.
And I wanted to try to see if there was a better way of doing this, even though I cannot be 100% sure that this will never happen again, and that this is something that if you use pressure enabled delivery won't happen. That is the main rationale for it. And this is the main difference between conventional thyroid artery embolization and pressure enabled delivery. We use a special device that is a pressure enabled delivery system that has a smart valve at the tip of the catheter.
Hmm.
This valve looks like a little cone of shame, the one that you put on a pad or something like that.
Hmm.
That's kind of like how I always picture it with my patients. And the little cone opens up, the smart valves open up against the vessel wall.
Hmm.
And when they do that, they create a pressure differential. And by doing that, they generate a vortex at the tip of the catheter. And when
Hmm.
you do that, you facilitate forward flow, number one. And number two, this valve, it's kind of like V-shaped, right? It's open like that against the vessel wall. And when the heart pumps blood, it collapses. And when it doesn't pump blood, it opens up. So when it opens up, it kind of like the particles that are lingering here, they're caught by this smart valve as well. So they kind of like prevent reflux. When this product was initially described, it was actually described as an anti-reflux catheter. So it serves those two purposes. It allows forward flow by creating this pressure differential, allows your particles or your embolic, the material that you're using to clog up the blood vessel, to migrate more into the parenchyma of whatever you're trying to occlude, and also is designed to prevent reflux, which is the main thing that we think happens when people have a stroke during these type of procedures. So it's just a better tool. It's just technology applied to try
Hmm.
to make a procedure safer and have better outcomes.
Kind of in my mind envision when you said the cone of shame, I thought that was so great because I was thinking about an umbrella kind of like
Well, but
capturing everything.
yeah, it's an inverted umbrella.
Uh-huh. Uh-huh.
This is how the catheter looks like. So you have here this inverted umbrella. Okay. And this is made out of metal that is very flexible.
Uh,
And then here you have a screen that covers that little umbrella, which means that whatever is coming back on you is going to get captured by that little cup.
Okay.
And this is what we call the smart valve. And that smart valve gets opposed to the vessel wall. And because this is partially occlusive, while the heart is not beating, it's not sending blood forward. That's what creates that pressure differential and allows forward flow more efficiently. And this is how it looks like. So this is pressure thyroid artery embolization in the thyroid. So you can see here in the middle of it, you can see the thyroid gland. This is your carotid artery, which is the one that goes into your brain. This is the superior thyroid artery, which goes to the top of the gland. And then we have the subclavian artery, which is the one that goes into your hand. And this is the inferior thyroid artery. And this scheme is representing the little inverted umbrella inside the inferior thyroid artery. And the flow models, what we have seen is that if you measure the pressure before and after, there's a pressure gradient, and that allows forward flow. And this is the little vortex that you create. And that's why embolizing particles with this vortex phenomenon becomes more efficient when you're delivering particles inside a tissue.
Okay. So I remember as I was reading about this, it said that actually created a greater embolization of the gland because of the pressure.
Correct. So because you have this pressure gradient, you're able to force, if you will, more of these tiny little pellets to migrate deeper into the gland itself. And that generates a more profound ischemia. And that was reflected in our results because our median is the number in the middle, right? It's not an
Mhm.
average. There's a difference.
Right.
But is the median, which is the number in the middle, the median volume reduction for us was 73%, which
That's
is
crazy.
the largest volume reduction rate that has ever been achieved in the literature with one
Mm.
single treatment, especially in these very large glands. And as you pointed out, our median volume was about 117 mLs, which is almost 5 times as large as the normal thyroid. So, and that just it's a testament of how deep of an embolization you get with this particular device and how deep embolization you get with this particular technique.
Mhm.
And to put more into the sauce, so to speak, pressure enabled delivery differentiates from the conventional way of you performing thyroid artery embolization because we don't have to access the carotid circulation.
Mhm.
What we were able to figure it out is that in these very large glands that have multiple nodules or that have a diffuse process such as Graves' disease, that means that the whole gland is affected. It's not just a portion, it's not just an
Right.
encapsulating nodule, it's the whole gland that is affected. What we were able to understand is that the superior thyroid artery communicates with the inferior thyroid artery inside the gland. Okay.
Mhm.
And when you put the smart valve catheter inside the inferior thyroid artery without accessing the carotid circulation, you're actually able to communicate the two arteries from one axis. So the reason why it's very rare for me to go into the superior thyroid artery. I do it, but it is extremely rare.
Okay.
80 to 90% of my cases are completely performed from the inferior thyroid artery, which I think, in my opinion, potentially mitigates the risk of stroke. It's not zero, but at least you don't have to intervene in the brain, in the vessel that goes into the brain. You only intervene in the vessel that goes into your hand. And the only vessel at risk there is the vertebral artery, which is a couple of centimeters away from the origin of the inferior thyroid artery. So I think that that particular feature makes the procedure potentially safer. As you pointed out in our series, we haven't had a single neurovascular event. And I think that also it's something that is a finding that is very encouraging because it means that we're improving the safety or something that was already safe. For the people out there doing pressure-enabled delivery, it's something that I strongly believe in, but that doesn't mean that doing conventional thyroid artery embolization is a dangerous thing. It is a technique that if you're judicious about doing it, you can also get good results. But what we know so far in the literature, until somebody contradicts me in the future, then it means that the best results can be achieved with pressure-enabled delivery.
And for these patients that have these massive, massive goiters, they need a massive reduction in order to really notice the full effects. And so you mentioned again, the 73% was the median. So that means that there were people who had much, much more than that at 6 months. I sometimes have patients who ask me, is it going to completely go away? Talking about any kind of treatment for a thyroid nodule. Is it going to have a 100% reduction? And I have to explain to them, no, the only 100% method is going to be surgery. So we have to be more comfortable with these percentages that are not 100%. And as we were talking about earlier, with thyroid nodules being ablated, a thyroid nodule ablation that gets a 70% reduction, that's an excellent reduction, because you're going to have symptom relief, you're going to have relief of the visible aspects of the thyroid nodule. And typically, those are smaller nodules, less than 20 milliliters. Well, we're talking about nodules that are 100 and
17, right?
117. That's quite a bit larger. And so for someone to have a 73% reduction of such a massive gland, that's going to improve their quality of life in massive and significant ways. So we have to just kind of keep that in the front of our mind. It's not going to be 100%, and that's okay.
I 100 agree. I 100% agree with you. It's just, I mean, having these conversations with patients, it's so important. I like personally to make my patients at the front and center of the decision.
Mm-hmm.
I always share every single possible alternative that they may have, even though that some of my patients always come with a plan in their heads. And sometimes I tell them, like, listen, I just don't think this is the right thing for you, but listen, this is the array of possibilities. And I do that with the intention of aligning goals, aligning expectations. Because if you and I are at the same level and you and I are aligned in terms of expectations, then we're for sure going to have a good outcome. And remember that here, the most important thing, and I'm glad that you brought up the size thing. Here, we're talking about quality of life. That's the
Absolutely.
most important outcome here. It
Mm-hmm.
doesn't matter if your volume reduction is 10% or 20% or 90%.
Mm-hmm.
I feel that it's a 10% volume reduction. You feel better with yourself. You don't have the pressure anymore. Then kudos. That's what we
Mm-hmm.
wanted, right? Like these
Totally agree.
benchmarks, we have gotten these benchmarks in a way of trying to quantify things from the medical standpoint of view. But ultimately, the important thing is that you get better. What we're trying to do with our study, the PROTECT study, the PROTECT registry, which is the multi-institutional study that we're running on pressure-enabled thyroid artery embolization through the country. And our main outcome, it's not volume reduction. Our
Mm-hmm.
main outcome is not how good your blood tests are. I mean, obviously, we want to measure those and we want to measure
Right.
the volume, but what we're actually measuring as our primary outcome is, are you better? And it's
Right.
not an subjective, yeah, I feel better. No, it's an objective, I feel better, with a very validated scale for thyroid disease that is called the Thypro questionnaire, that has been validated before in these procedures. And I think that that's truly the way we should move towards to. That's the way we're going to move the needle in this field, if we are able to improve how people feel by doing minimally invasive therapies.
Could not agree more. I actually have done a few physician onboarding meetings where I'm actually working with a physician who's just getting started doing an ablation technique to kind of help them see what the patient side is like, so that they can kind of have a mindset of, how can I best set up my practice to help have the best success for everyone, patients, doctors included. And that's one of the things I've tried to kind of hit home is that, we've got to get the reduction of the nodule. While that's important, we don't want to focus on that at the expense of the quality of life. The quality of life is really the most important thing because, when I think about my own experience, I couldn't sleep, I couldn't eat, I couldn't live. Like I literally was in just a constant state of panic from feeling like I was being choked and I was exhausted and had children, little children, and I couldn't function. And that is no way to live a life. You only get one. I think that's fantastic that you're measuring all of that in addition to the hard data, like the numbers on the measurements and the hormonal success. Hey, just a quick break to share something I'm really excited about. My brand new website, saveyourthyroidwithjen.com. You can head there to subscribe to my mailing list and stay in the loop about new podcast episodes, videos, and updates in the world of thyroid nodule care. And I'm now offering something new, one-on-one patient navigation services. If you're feeling overwhelmed or unsure about your treatment options, I'm here to help. As a patient who's been through this myself and spent years learning from some of the world's leading experts in thyroid nodule treatment, I can help you make sense of your choices and feel more confident in your next steps. You can learn more about patient navigation and everything else I'm working on at saveyourthyroidwithjen.com. Now back to the conversation. Just to kind of circle back to what we were talking about with the findings of your paper that you published, the 73% median reduction, and then 71% of hyperthyroid patients returned to normal. That's incredible. So how is blocking the blood flow to the thyroid gland leading to this normalization of hormone levels?
So many patients, so this comes to the natural history of the disease. People don't know this, but this is the natural history of the disease. When you have a multinodular goiter, goiters grow at a rate about 4 to 9% per year, give or take, okay, depending on the paper that you look. So that means that they're not going to get any smaller, okay?
Unfortunately.
And also what we know when we take a look at the natural history of the disease, up to 30% of patients that have a multinodular goiter over a period of 7 to 12 years, they will become hyperthyroid because there is this hyperplasia phenomenon.
Okay.
And hyperthyroidism, it's a big problem.
It is.
I mean, the first cause of hyperthyroidism is Graves' disease, and then autonomously functioning nodules or autonomously functioning goiters are the second more frequent cause. And it's a debilitating disease. It leads to osteoporosis, cardiovascular disease, strokes on its own, potential for a heart attack. There's a lot of things that come with hyperthyroidism. Indeed, hyperthyroidism is an absolute indication for you to do something when you have a nodule or a overacting goiter. And that's why everybody gets blood tests, because we know that, if you have hyperthyroidism, that means that it's a pretty good chance that your goiter has acquired autonomous function, meaning that it's completely independent from the brain control. And what we do in those scenarios is that we try to do a test that is called a thyroid uptake test that allows us to localize which nodule specifically or which side of the thyroid is actually responsible for that overacting or that increased in function. So if you're able to determine which nodule or which side of the thyroid is actually responsible for the hyperfunction, then you can target it. And that's what we do with this procedure. Like if we are able to document that, then we decrease the blood supply to that area. We generate an infarction, a controlled infarction, and the cells that were reproducing very rapidly, they just die. And that's why the brain is able to take over again the control of the thyroid. So we're definitely more successful in patients that have primary hyperthyroidism, meaning that they don't have a Graves' disease or something like that, that it's just the goiter itself or the nodule itself that is overacting. Because as we know, Graves is a more diffuse process, is an autoimmune process. It's something that doesn't have a cure. It can be managed with medications, with surgery, or by with this technique, but we've seen less success rates. So what we've seen is that we're closer to 80% of normalization of the function if you do not have an autoimmune process. Okay. If you do not have Graves. If you have Graves, our success rates are far less than that, are probably around 50 to 60% of
Hmm.
normalization of your tests. However, we have seen also that in the patients that have Graves disease that do not return to normal function, at least their dosage of the anti-thyroid medication goes down. And that's something that is
Really?
also an important outcome, because the anti-thyroid medications have some degree of side effects and undesirable side effects as well.
I just want to touch on that for a second, actually, because if the success rate is not as high for Graves' disease, is there still? It seems to me like there still is kind of a use case for this in certain situations. Like you talk about women who are still in their childbearing years, they don't want to undergo radioactive iodine, which has side effects such as infertility, can lead to breast cancer down the road.
And hypothyroidism, more
And then
importantly.
hypothyroidism. So, is there a use case for potentially doing this, even if it's not 100% successful, if it can stem the tide somewhat, or at least is it worth trying before resorting to some of these more intensive solutions that have basically burned a bridge that you can't go back from?
I, I think so, because at the end of the day, I believe it's a safe procedure. As I
Hmm.
said before, it does carry risks. It does have complications. There's experts throughout the country that can do it very judiciously, and I think it's worth a shot. Like, if I tell you, Jen, you have 60% chance of winning the Powerball tomorrow, would you go and buy the tickets? I
Absolutely.
would absolutely buy them. I would absolutely buy them. You don't have to ask me. I will run into the drugstore right now and buy all the Powerball tickets. So
Yeah.
I think it's worth the chance.
Yeah, yeah, I agree. I agree. I just wanted your thoughts on that. Because I know some people who have Graves' disease who are in that very scenario. They're women, they don't want to have radioactive iodine at this point in their life. And, they're not finished. Either haven't finished or they haven't even started a family yet. And, that's a lot to ask of a young woman to trade her fertility for her thyroid being properly functional. So I'm glad that we touched on that. Well, let's get back into, we talked about the pressure enabled delivery and the safety and how this is a technique that uh, is just a safer approach. Now, you're going into these arteries through the patient's wrist. In the literature, it seems that the other option was through the groin. How is the wrist better than going through the groin?
It's not necessarily better.
Okay.
They're both comparable, and they're both standard of care. So for us, for interventional radiologies, we're used to do procedures both from the wrist or from the groin. There's a theoretical advantage of going through the wrist. Is number one, it's a more favorable angle to go into the inferior thyroid artery. As I said before, 90% of my cases are performed only from the inferior thyroid artery. So if it's a straighter shot, then that's a theoretical advantage. Number two, remember that, and this is an opinion, I cannot back it up scientifically, but philosophically, when I'm doing this procedure, in my mind, I want to do everything I can to prevent a bad outcome,
Mhm.
everything I can to prevent a stroke. Even if the incidence is extremely low, 1 to 3%, I want to do it so it stays as close as zero as possible.
Totally agree.
And when you're using the subclavian artery, which is the one that comes from your hand, you're avoiding crossing what we call the supraortic vessels, meaning the vessels that go into your brain. If you have a vessel like that is going into your brain, and then you have a catheter that is crossing in underneath and can potentially limit the flow that goes into your brain, that
Mhm.
is a risk factor for you to have a stroke.
Okay.
And if you're elderly folks, they have calcifications of their vessels. So you don't want necessarily to manipulate catheters in that area because you can flick these calcifications and send them
Mm-hmm.
to the brain. That's another reason why angiography on its own, it can potentially cause a stroke. That is the philosophical approach. And number three is because this procedure is an outpatient procedure. Nobody stays over in the hospital. They just come in, they get it done, they go home once they recover from the sedation and whatnot. If you do it from the groin, you have to keep your leg straight
Mm.
on a stretcher for 2 to 4 hours, depending if you are using a closure device or no, or if
Mm-hmm.
you're just closing it with pressure. And that can be uncomfortable for a patient versus if you use the wrist, you just use a tiny little bracelet that has a balloon in there, and then you can
Mm-hmm.
walk around. You can go to the restroom if you want to. You can kind of like almost ambulate a lip.
So logistically, it just works out better all across the board, sounds like.
Yeah. And I have to stand by for what I publish because it wouldn't make any sense if I publish something in the medical literature and I cannot back it up. And you know that one of the things that I do is I treat cancer, specifically cancer in the liver. And many years ago, when I was in the academic world, I published a randomized controlled trial that compared the femoral approach against the radial approach. And it was a patient preference. It was a trial that was designed to determine which one was a better approach for patients, what
Mm-hmm.
patients wanted. That was the whole point of the trial. And universally, patients preferred radial approach. Is far more comfortable. And it was one of those trials that the statistical differences were so overwhelming that we had to stop the trial early,
Wow.
which doesn't necessarily happen very often. So just to say that, I have to do what's best for my patients,
Mm-hmm.
and I have to do what's best for their comfort and their care. So that's why I choose that approach.
I like that. Very cool. Well, you already mentioned the trial, but we're going to talk about that a little bit more in depth now. So, Sarasota Memorial is the lead site for this new 10 site registry study called the Protect. And what quality of life metrics, we talked about quality of life being super important, are you trying to capture in this larger data set?
So two things there. We're calling that protect because we
Hmm.
want to protect people. That's
Yeah.
what we want to do. So that's one of the first messages of the trial. Number two, the main outcome, it's quality of life questionnaire that has been standardized specifically for thyroid diseases that is called the FIPRO 39 questionnaire. It's a questionnaire that is very simple. It has 39 questions. It sounds like a lot, but truly it takes about 3 to 4 minutes to fulfill. All my patients fulfill it like while they're waiting for the consultation or they do it online if we're meeting via telehealth. And we then measure it every 3 months until they are out of the follow-up period. This is a retrospective study. So we're just gathering this data. We have seen already like significant differences in the quality of life scores, and actually has been published before by Dr. Yilmaz from Turkey in 2021. So when he published his paper, he used this score and he also demonstrated a significant improvement in quality of life. So that's why we feel that this is probably the best outcome that we can measure.
And so patients are always asking me, how can I participate in any kind of research? So, how can they do that?
So I can certainly share the National Trial Clinical Database website with you, so you
Mhm.
can share it with your patients. This is publicly available. It's publicly available data. Like everybody can search on the web for the Protect registry and thyroid artery embolization, and you can see kind of like the people that we're trying to get into the registry. Which honestly, it's all comers. We want to make sure that this technique can
Mhm.
be reproducible. That's the most important thing. That this is not just a Juan Camacho thing. It's just that it becomes something that it can be reproduced by many physicians throughout the country. So it is publicly available, number one. And number two, we have very renowned institutions throughout the country. We have Mayo Clinic, University of California, San Francisco, University of California, UC Davis in Sacramento. We have all of the sites they're cited over there, but we have sites in the Midwest, Northeast, Southwest, West Coast, and we did that with the purpose to make sure that we were kind of like geographically
Yeah.
represented throughout the country.
And I think it's fantastic because up until you told me about this, I was literally only aware of maybe 2 sites in the country that were offering thyroid embolization. So this is a having more access, greater access for patients is so important for their ability to access care, appropriate care for their thyroid nodules. Once this data is published and we see the advantages, what advantages there are, do you think it's possible that this pressure enabled delivery of TAE could replace sternotomy as the standard of care for these large goiters? Do you think that's possible?
I certainly hope so. I think that I haven't met, and I'm talking a little bit with passion up here, right? I haven't met the first surgeon that is an ENT or a dedicated thyroid parathyroid surgeon or an endocrine surgeon that
Mhm.
loves to do sternotomies on people.
Right.
It requires a lot of coordination. You have to
Yeah.
talk with your cardiothoracic surgeons or your lung surgeons, and it's usually a bigger surgery. Patients get admitted for days. The
Yeah.
pain that comes out of the procedure, etc. So it's not a surgery that is enjoyable. Number
Mhm.
one, and number two, we do not. I feel we need to get out of our heads in terms that we don't need to make every patient absolutely perfect.
Mhm.
Like, you just have to accomplish improvement in quality of life. So if you have the option to do a procedure through a pinhole in your wrist with no scars, yes, it does have risks. It absolutely has risks, but that it has very good chances of improving the symptoms that you're feeling. Why don't give it a chance to that? And we're really, really working hard in the a national level with multiple societies, and we're trying to make consensus and establish guidelines to use this procedure because, as you said, I think that the main thing is awareness, then training, and then
Mhm.
reproducibility. And that's what we're trying to do. We need to make sure that all of our doctors are informed, that they're talking with facts,
Mhm.
and that they're discussing these options with our patients in a very sincere and open fashion.
I love that, and I think that as you are able to make the procedure even safer, because as you said, it's already safe, but improving in ways that can prevent the risk of stroke and prevent that permanent scarring on you as the physician, that's gonna increase adoption, I believe, of this procedure far and wide because it'll be seen as this very safe, easy procedure that we can do that it saves the patient from undergoing this terrible, very invasive surgery that, probably can't be repeated if it needs, if it needs to be addressed again in the future, probably carries a great deal of morbidity with it. And also, as you said, it's just not an enjoyable surgery for the physician. So I would like to just kind of close this out with thinking about patient advocacy. If a patient is in this position, they're diagnosed with a massive goiter, it's diving down into the chest, and they're being pushed towards surgery, maybe from a physician that's not aware of these types of options. What specific questions should they ask their physician or their surgical team about your findings in the study?
I think that first of all, and my message to all the patients is that within medicine, within every practitioner, and myself included, we all have some degree of bias. That's
Yes, we do.
that's that's just the way it is. I would not trust a practitioner that boxes me into one single treatment.
Mhm.
And I would not trust a practitioner that tells me this is what you have to do, period.
Mhm.
Because ultimately, you're in charge of your health. You are the driver's seat, and you always should have options. At least explore them. Some of the options, sometimes they're not good. And I tell the patients or my patients very openly and candidly, I will say, like, listen, if you were my mom or my family member, could I do an ablation for 150 grams gland? Possibly. It's going to take me 3, 4 sessions, several sessions.
Mhm.
Is it going to be the best thing for you? Probably not. So I think that you have to talk about this with transparency. You have to talk about this in a multidisciplinary fashion. And you as a patient are always in charge of your health. So you should be in the hands of a practitioner that puts you front and center. That's the most important thing. So always advocate for yourself. Try to ask if there's any other alternatives. All physicians are usually aware of alternatives, despite their own little biases. So I think that if you're a good doctor, you should be mature enough to tell your patients that there are other alternatives. And if you don't know about the alternative, you can say, hey, listen, I've heard about this thyroid artery embolization thing, but then you can talk to maybe Dr. Camacho or look for other resources. And I can try to refer you to somebody within my network. And I do that all the time with my endocrinology partners and with my ENT partners. Like, I don't know enough about minimally invasive thyroid surgery or transoral thyroidectomies or transaxillary. I'll be more than happy to refer you to a surgeon that does, so you can have an open conversation about it. I don't do this for the money. And I don't have to render any account to anybody. My only accountability is because I want to take care of patients. And that's why I tell them, like, I tell them front and center, like, listen, I don't care if I do 1,000 thyroid artery embolizations or one. If that one that I do was meaningful and was indicated and was the right patient for me to intervene on, that is what makes me sleep at night. So you have, as a patient, you have to advocate for yourself and always almost demand options. And if not, then use resources like your platform. Your platform is amazing and it's fantastic because you help so many people. And it's because of that. You don't advocate for you have to do RFA.
Right.
You don't do that. You offer a platform to educate people, and that's super valuable.
Well, I think it's true that, knowing as a patient that you have the power to shop for whatever treatment options are out there. It's not that you are limited to what the doctor offers you. Just because it's not being offered by your doctor doesn't mean it's not out there. And that's a mindset that I think a lot of people are kind of breaking out of in today's society, but it's hard because as patients, we've been trained to, well, I go to the doctor, I ask the doctor, and the doctor gives me the answer, and that's where it ends. This idea of I'm going to call a doctor in another state, in another city, in another country sometimes is very foreign to us, and it's slowly becoming more common. And I'm so grateful to you for all of this conversation we've had today and for inspiring so many other physicians out there to adopt a technique that can help this group of patients that just really desperately need alternatives. I'm going to put on the screen and in the description below all of the sites for the PROTECT study. And if you're a patient who is looking for a treatment option for a massive goiter or hyperactive gland, I highly encourage you to reach out to one of these providers or to Dr. Camacho. So thank you, Dr. Camacho, for joining me today. It's been a pleasure as usual.
Thank you, Jen. I really appreciate it. Again, thank you for everything you do for people, for our patients. You're empowering all of the people and educating them. This is a fantastic platform. Us as practitioners, we should be thankful that there's people like you that want to make a difference. I appreciate you.
That wraps up today's episode. If you found this valuable, please like, subscribe, and share it with someone who might benefit. You can find links to everything we discussed in the show notes below. Find a physician, discover treatment options, and join our patient community at saveyourthyroid.org. To stay up to date on new episodes, resources, and expert insights, be sure to subscribe to my mailing list at saveyourthyroidwithjen.com. It's the best way to stay connected and informed. There, you can also find all podcast episodes and book a 1-hour patient navigation consult for personalized guidance on your next steps. As always, please remember this podcast is for informational purposes only and is not a substitute for professional medical advice. No endorsement is given or implied for any specific product, treatment, or physician mentioned. As always, consult with a qualified healthcare professional for your individual needs. Thanks for listening, and I'll see you next time.